Good afternoon, and welcome to this month's Northern Virginia Health Policy Forum. My name is Linda Rouse O'Neill. I'm the Vice President of Health Policy here at Applied Policy. We're a health policy and reimbursement consulting firm based in Alexandria, Virginia. I'm actually thrilled that the first one that I get to host here at Applied Policy is on rural health. I actually started my career a long time ago in rural health, and it is something that is near and dear to my heart. So I am thrilled that we are here and that we've got a rock star panel to join us today to share their expertise and their passion for rural health. To kind of set the stage, in case you're not as familiar with rural areas as some of the folks on the panel are, there are more than 60 million Americans that live in rural areas. Many of them are older and sicker than the folks who live in cities. And today we're joined by three leaders in the effort to improve the quality and the availability of healthcare for these millions of Americans and ensure they have a better quality of life. So please join me in welcoming Bill Finner-Frock, who is the co-founder and longtime executive director of the National Association for Rural Health Clinics until he retired a few years ago. And we'll let him tell us in a few minutes how he has maintained being active. Sarah Homan, who is the Director of Government Affairs at the National Association of Rural Health Clinics, and Amy Elizondo, who's the Chief Strategy Officer of the National Rural Health Association. Welcome to all of you, and thank you so much for taking your time to join us today for the forum. So we're going to start with a couple general background questions. Then we're going to jump into some of the key issues, and then we're going to wrap up talking a little bit about solutions. So to start, I'm going to have each one of you share a little bit of background on your organization and its focus on rural health. And Bill, we're going to start with you.
Well, thanks, Linda. As she said, I'm Bill Finner-Frock. I was the co-founder of the National Association of Rural Health Clinics. Retired a couple of years ago. I continue to serve. We have a foundation, and I'm on the board for the Rural Health Clinics Research and Education Foundation. I'm also on the board for an organization called Movement is Life that works on eliminating health disparities, particularly in musculoskeletal health due to race, ethnicity, gender, and geography. And I do a little bit of teaching and writing. And so that's kind of what I guess brings me here. I'll let Sarah talk a little bit more about NARHC and the organization. In terms of workforce, I mentioned I have done some writing last year. I had a paper published by Paragon Health Institute looking at how we designate shortage areas. And I think there are some serious deficiencies in that area. We're essentially using a methodology that was designed for 1970s workforce to make 2025 workforce policy decisions. And in particular, the fact that we don't recognize the role and the contributions of physician assistants and nurse practitioners in our workforce is a serious shortcoming and really needs to be addressed. And so I think there's a lot we need to do in terms of looking at what is the rural workforce, who is actually out there delivering care, and ensuring that we have policies that support the types of professionals that are there, and perhaps less emphasis on providers who used to be there but are no longer there in significant numbers.
Great. Thanks, Bill. That's a great way to both tee up Sarah, and we will come back to workforce in a few minutes. And I think we need to talk to you about the definition of retirement, because that sounded pretty darn busy of you. So Sarah?
Yeah, thanks so much for having me. My name is Sarah Homan, and I'm the Director of Government Affairs for the National Association of Rural Health Clinics. So NARHC represents the 5,600 plus RHCs providing care to over 39 million Americans. RHCs are CMS designated outpatient providers. And I've been with the association for about 4 years, do both the advocacy side of things, and also we have a significant role in educating the professionals who lead these facilities. It's great to be here.
Great. We're so glad that you joined us. And then Amy.
Hello, I'm Amy Elizondo, and I serve as the Chief Strategy Officer for the National Rural Health Association based in Washington, D.C. We're a nonprofit membership organization with a mission to provide leadership on rural health issues through advocacy, communications, education, and research. We have over 21,000 members around the country representing rural hospitals, rural clinics, physicians, allied health professionals. We also have 45 state rural health associations around the country as well.
Great. So as we can tell, we've got a wealth of knowledge on the panel, but we're going to start with a little bit of an easy question to start things out in a little bit more of a fun way before we start to get into some of the more serious issues. So just give us a quick sense of what got you interested in rural health. And we're going to start with Sarah on that one.
Yeah, happy to answer this one. So I grew up in rural north central Pennsylvania. And, growing up, I didn't necessarily know that there were people advocating for the healthcare access and quality that I had, regardless of where I lived in the country. And so when I learned about that in college, I went to Penn State and learned about it. The Pennsylvania Office of Rural Health is based on Penn State's campus. And so I became connected with them, initially interned in the office I'm now with, and then have been here ever since. So once I learned about, again, the fact that there were people advocating for the access to healthcare that I had, that my family has, my neighbors have in those communities, it was something I knew I wanted to be part of.
A great story. Awesome. Amy.
I am originally from a small town called Mercedes in South Texas. I usually tell people that I'm from South Texas originally, and they say San Antonio, and I have to remind folks that there's still 5 hours worth of Texas after San Antonio. But I grew up in this small town, and my dad was a Vietnam veteran. And at the time when I was growing up, he would seek or get access to some of his VA benefits, but the nearest place to do so was in San Antonio. So we would drive 5 hours for him to get access to some of his VA benefits there. And it wasn't until I moved away to college that I realized that wasn't the norm. I was used to having driving long distances with my family for primary care, specialty care services. And so going off to college, I went to Texas A&M University and, realized that there was better access in larger areas. So my family is still in South Texas. And so, the impacts of access are still very much present for them. And it's always been, at my core and reminding me, I do kind of what I do because I've lived through some of those experiences and know that it's still very much an issue. But very glad to be part of that part of the country. And, again, still very near and dear to my heart.
That's great. All right, Bill.
Well, unlike the three of you, my exposure and connection to rural is a learned experience rather than a lived experience. I grew up outside of Philadelphia, where I had access to academic medical centers. I literally had like 5 community hospitals within 15 minutes of where I lived. I had a doctor immediately across the street. I had a doctor right up the street. And I was in a little town for our area of 4,000 people. I didn't learn about rural till I went to work for a senator from Iowa. And the first time I went to Iowa, we were driving, and it was quite apparent as you're just driving and driving, and you got corn on one side of the road and soybeans on the other side. And for variety, they would switch them back to the other. And the immediate question arose, where do you, when you have a high school football game, where's the team that you're going to play? We need healthcare. Where do you go to the hospital? Where do you go to the clinic? And everything was incredibly far away. And just the opposite of what the two of you had experienced was I just assumed that everyone had healthcare close by. They had a hospital easily accessible. They had clinics easily accessible. And that wasn't the case. And so when I came to Washington and started working on health policy, and I was working for the senator, that was one of the issues. And at that time, there really was no NRHA didn't exist. There was really no one talking about rural until really the mid to late 1980s. And so that was how I got into rural.
I love it. 3 sort of different stories, but with the same passion behind it of wanting to make a difference and to make sure that the quality of life was still, and healthcare was accessible, right? Regardless of where you live. And I kind of had that similar path growing up in a rural area, but my rural area was nothing compared to Wyoming, which is the senator I worked for. I remember clocking an hour that I went without passing a car. And that was definitely eye-opening, for sure. So talk a little bit about who we all are, the organizations that you all are with. And I think it's time to start to get into some of the challenges that we've got facing us in rural health. And one theme as we were prepping for this webinar that keeps coming up is workforce. And Bill touched on this a little bit in his introductory remarks. So can you share a little bit about your perspective on our workforce challenges in rural America and what kind of makes the rural healthcare unique when it comes to those challenges? And this time, let's start with Amy.
Sure. I mean, as Bill touched on already, you know, there are a health professional shortage areas in rural communities. So already puts a lot of rural communities at a disadvantage just trying to find basic access to primary care. We have a lot of, you know, programming and support around recruitment and retention to draw more physicians to practice in rural. Studies have shown that rural areas that have an investment or students that grow up in a rural area tend to come back and practice in a rural area. We're starting to see those numbers dwindle. And so the need for improving workforce numbers is still very much there. We know that folks still travel long distances to try to get access to basic care. We know a lot of physicians are retiring out as well, kind of hitting that era of losing some of those main primary care folks that have been at practice for decades. We've also seen just how a lot of burnout has occurred, especially since the COVID-19 pandemic, also very much impacting rural communities. The concept of traveling nurses and is also impacting rural areas as they've gone to practice in other areas, but also get quite the income, which is a really hard thing to say no to. So they're incentivized. And so again, kind of drawing the workforce away from rural areas. But a good highlight and still very much needed, though, I will say, is, you know, the community health worker model, which is also a critical part of the rural healthcare workforce. They're often very much a lifeline between the patient and the provider in rural communities, and just trying to help get patients from point A to point B, but also serving as that conduit, that trusted member of the community that can convey information in a timely fashion and also support the physician in trying to relay that to the patients as well.
Great, thanks. Lots of challenges, and then you gotta compete, right, from a financial perspective, which makes things really difficult in rural areas. Bill, you kind of touched on workforce in your introductory remarks, so this is your chance to explore that a little bit more.
Sure. Thanks, Linda, and thanks, Amy, for your perspective there. I think what we are overlooking in workforce is the role and contribution of PAs and NPs. So as Amy mentioned, we have a large number of health professional shortage areas in rural communities, and the data demonstrates that. But the problem with that is that we don't count PAs and NPs in those communities. So as an example, you know, we have the Rural Health Clinics program, and there are over 5,000 rural health clinics located around the United States. By law, each one of those RHCs must have a PA or nurse practitioner on site and available to provide care. So that means there's, at a minimum, over 5,000 PAs and NPs working in rural underserved areas, which is a stipulation for being a rural health clinic. You have to be located in a rural underserved area. The federal government doesn't count them. So when we identify a shortage area, we put a rural health clinic in that area. We recruit a nurse practitioner or a PA to that community. They're working there. The federal government says, well, you're still a shortage area because we're not going to count the PAs and the NPs that are there. And if we were to count them, we would see a significant drop, this is in my paper, in the number of health professional shortage areas and medically underserved areas. The significance of that means is that we're better able to target the resources that are necessary for communities that are truly underserved versus those who aren't. Now, as part of that, we would need to grandfather in those facilities that are that have been successful. You know, what I refer to as the yo-yo effect, where you have a shortage area, you recruit a professional to be in that area, they're no longer a shortage area, in theory, they would lose their designation and therefore their ability to participate. So there are some things we have to work through to make sure that that happens. But the key is that we have to have a workforce policy in 2025 that reflects the workforce that is available. We have almost 1 million PAs and nurse practitioners. They have over 600 nurse practitioner and PA programs today. It's time we counted them and counted the contributions they're making.
Great points. In terms of helps increase that availability of healthcare workers that are out there in rural health. And oftentimes those are the folks that are willing and more willing and able to go out to those communities as well. Sarah, you get to wrap up on workforce.
Yeah, thanks. I just want to add a couple more notes on NPs and PAs and their role specifically in RHCs, and how we certainly have a workforce challenge, but how existing laws, oftentimes outdated laws, can actually be a limiter in, again, using the workforce that we already have. So nurse practitioner and PA licensure is determined at the state level. So they have reduced, restricted, and full practice. So can they operate independently, and like their sort of the levels of independence that they can practice in. In RHCs, it's sometimes more restrictive than it would be in a non-RHC down the street for those states that, for example, have full practice for their nurse practitioners. And so this was written in 1977 when the program was created. And since then, obviously, every state has a practice act governing those specific practitioners in those states. But that's a challenge that we see because, you know, if they practice down the street, perhaps they could practice completely independently, and maybe they're interested in opening their own rural health clinic, but can't do so because they still need to have an MD or DO on staff. And so some of those areas seem small, but of course, workforce is too broad of an issue to deal with if we don't tackle sort of those smaller areas that maybe are outdated now and can see some improvement through those small tweaks. Another thing I would just add on resource allocation, you know, a lot of the ways that we try to tackle workforce, as Amy was touching on, is through pipeline programs and workforce grant dollars and things like that. Despite being such a significant provider in rural America, there is no specific grant program unique to rural health clinics. And so we're not broadly paid through a grant mechanism, and that's okay. We're more reimbursement focused. But in areas like workforce, I think there's a lot of opportunity to specifically target grant dollars to one specific facility type like RHCs, and see where we can make some improvements there.
All great points. And I've already mentioned some of these outdated laws and the certifications that are happening, and sometimes making a couple tweaks, as you mentioned, as we know in the policy world, can have a huge impact on the broader goal around workforce. So great points. And before we move to the next question, I just want to make sure that everybody in the audience saw what Annie put in the chat. So if you've got a question for the panelists, please put it in chat. We're going to compile those and ask them all towards the end of the program. Sometimes it's hard to remember your question though to the end. So if anybody said something that catches your attention or you want more details on, please don't wait to the end. Go ahead and type in your questions, and we will, but we'll ask them later in the program. So talk a little bit about workforce. Changing a little bit to another hot topic when we think about rural health is telehealth. That comes up quite a bit. It was also pretty timely that we've got the webinar today, given that Congress just extended the Medicare telehealth flexibilities for 6 more months when they passed the continuing resolution to keep the government funded through September 30th. So can you share a little bit about your perspective on telehealth and rural health, and what else can or should be done in this space? And this time we're going to start with Bill.
Thank you, Linda. Telehealth it's a technology that's been around for a while, but it's only been really since COVID that it has really emerged as a significant contributor to delivering healthcare. And it's really a key contributor, and it was unfortunate that it had to be COVID that drove it. But the good news is that it appears that is now being embraced. But unfortunately, we have payment policies and coverage policies that, again, are archaic in the sense that they are indicative of a system that assumed that every visit and every interaction was going to be face-to-face, live, real person to real person. and doesn't really acknowledge in a way that it should the contributions of telehealth. Now, it's important, and I'm sure Amy and Sarah will also touch on this, that we recognize that while telehealth has a role, it is not a complete substitute for the availability of in-person care. And some people say, well, you use telehealth and that'll solve the problem. We don't need to put providers out in these rural communities. We can just service them via telehealth. And that's a real unfortunate, and that is a mistake. There are services that it can provide. There is access, specialty access, follow-up visits that it can occur. I think mental health is an area where there's tremendous opportunity to make mental health services available in rural communities where we're never going to be able to recruit an actual provider in that to come to that community simply because the volume and the demand are not sufficient. And so telehealth is great. It has a role. It should be expanded, but it is not a complete substitute for the availability of in-person care.
All great points. Sarah?
Agree with the points that Bill made, and just to drill down on a few of the limiters as of how policy is written right now. So since early 2020, when Medicare telehealth flexibilities specifically were rapidly expanded, fee-for-service providers, so traditional outpatient office providers, receive parity between in-person and telehealth visits. That's been the case in all of these extensions that Congress has passed since early 2020. Our safety net providers, though, so rural health clinics, federally qualified health centers, do not receive reimbursement parity between the two. And so we receive significantly less for a telehealth visit than an in-person visit. And while Bill's entirely right, this is not a perfect solution as a replacement for in-person care. There is a really strong opportunity for it to serve as a great complement to that access, but not when we receive significantly less for it. Because of how we bill and code for it, we also get a lot less data from the telehealth structure that we're under right now. And also not to ignore the fact that we get these very short-term extensions at any given time. And so while Congress can sort of say, great, pat ourselves on the back, we passed a telehealth extension by the time it was going to expire, for providers that are not sure if they can schedule telehealth appointments 2 weeks from now, before this was passed, but just an example, 2 weeks from now, because Congress hasn't yet passed it, it doesn't mean anything to those providers that telehealth is bipartisan and really popular if we're still coming down to the wire at every single one of these extensions. So I would just say the timeline of these is not allowing telehealth to really sift itself out in terms of how it fits as that complement. Right now, the data shows that as rurality increases, telehealth utilization decreases, and that paints an obviously very different picture than the magic solution and the great opportunity of telehealth that a lot of folks are touting, which I think can be there if we fix some of these issues.
So, great points. I totally get what you're saying in terms of Congress has a habit sometimes of just, as we like to say, kick the can down the road 6 months, whether 6 months or even a year, and that doesn't always give the type of planning and not sustainability, stability, right, that people are looking for when they're trying to adopt some of those technologies and be able to make those work. Amy, any last thoughts on telehealth?
No, absolutely. The NRHA supports extending and just expanding to permanently have those telehealth regulatory waivers for reimbursement programs. And, it's definitely a game changer for rural communities. And our CEO likes to say, not since NASA landed on the moon has, telehealth just really positively impacted, access to care for rural communities. But there's still a lot of work to be done to enhance this and to make the ease of access, less of a burden for the providers, but also for the patient. So looking at, not just permanently extending these waivers, but also looking at payment models, to enhance and make sure that the payment is equivalent to in-person visits or services, and reauthorizing funding the Affordable Connectivity Program as well, to ensure that rural residents, including older adults, can afford this high-speed internet. It's obviously still a big issue for rural communities, and looking at enabling providers and patients to adopt telehealth technologies, including remote patient monitoring, through technical assistance, best practice clinical guidelines, and extended support for telehealth emergency care as well. And just generally supporting policies that can facilitate these cross-state licensures so that, again, there is more ease of accessibility and access for, again, the patient and the provider, taking away some of that burden and restriction for those.
All great points. We've got a lot of challenges. Telehealth sounds great, but you gotta have people adopt it. You gotta be able to afford it. And you have to also get folks to be able to use it and adopt it in their own home. So great points. Sarah kind of touched on reimbursement a little bit, and so let's go a little bit deeper. You cannot talk about rural health, in my opinion, if you don't talk a little bit about Medicare reimbursement and some of the challenges that rural providers have. There's also been some policy and focus around that. There were some provisions that were expiring at the end of the month that did not get part of the congressional continuing resolution that passed. So just from a big picture perspective, you can share some thoughts on either those provisions or some other reimbursement policies that your organizations are pursuing would be fantastic. And this time we will start with Sarah.
Sure, of course. So the benefit of pursuing rural health clinic survey and certification is enhanced traditional Medicare and Medicaid reimbursement that those clinics would then have access to. So it's a version of cost-based reimbursement subject to a cap. Broadly works pretty well for those patients that are on traditional Medicare, but I'm going to use my couple of minutes here to talk about those patients that shift from traditional Medicare to Medicare Advantage, which we're seeing broadly across the country, also a trend in rural, and what those reimbursements look like in comparison to traditional Medicare. And so again, this is from the provider perspective. There are reasons that patients choose MA or traditional Medicare. Certainly lots of valid reasons, but from the provider perspective, again, RHCs as an example, get that enhanced Medicare reimbursement, but that same protection does not exist when it comes to their Medicare Advantage contracts. So everything is left up to the terms of those contracts like any other commercial plan, and left up to their negotiating leverage or lack thereof. Oftentimes, of course, the plans are going to have more negotiating power than particularly our small independent providers. And what that means is that more than half of the RHCs across the country are receiving less or significantly less in overall reimbursement from MA plans in comparison to traditional Medicare. And so this is an important part of this conversation, particularly because even if patients are really big fans of their MA plans, but the facilities, the care that they are used to receiving in their communities is no longer sustainable because of the reimbursements that those providers are receiving from the plans, that could threaten access to that care altogether. So again, this is not traditional Medicare reimbursement. This is when those patients are shifting to MA and what some of those repercussions are from a facility perspective.
That's a great point. Overall, now it's almost 50-50, I think, in terms of Medicare beneficiaries who are enrolled in Medicare Advantage versus traditional fee-for-service. So great point. Before I move to Amy, there was a quick question from the audience that, since Sarah, it was about something you had said during telehealth, and they wanted to make sure that they heard right. So I'm going to try to refresh your memory on what you were saying about as their rural increases, sometimes rurality increases, telehealth adoption decreases. And they wanted to just make sure they understood if that's one, what you said, and maybe explain that just a little bit more, and then we'll move on to Amy on reimbursement.
Sure. Yeah, of course. So as rurality increases, telehealth utilization decreases. So we see it significantly more in urban populations than in rural populations. And of course, there's a lot of reasons for that, right? Broadband connectivity, provider and patient choice, and then that reimbursement piece is definitely part of it as well.
And so the rurality, I'm probably not going to say that right. When you're talking about that, are you kind of getting at, when I think about rural health too, right, then there's actually a frontier, right? As you get more and more rural, if you say, then the telehealth, is that kind of what you're getting at as well?
Yeah, if you're on like
Okay.
the urban to frontier continuum,
Yep.
Yeah, the further that you get, the less adoption is there.
Great.
And I think a good part of that like makes sense to a degree, but again, it runs contrary to a lot of the talking points about telehealth is so amazing for rural. Maybe not exactly.
Great points. Thanks so much for clarifying that. shifting back to Medicare reimbursement, Amy.
So one of the big areas alongside some of the points that Sarah's made already, just, the rural hospital closure crisis being a big issue for rural communities around the country. So looking at the Save America's Rural Hospitals Act and just a lot of the Medicare reimbursement factors within that. So very much support, making sure that there's a permanent elimination of the Medicare sequestration for rural hospitals, again, to kind of strengthen those areas and making permanent the low volume hospital and Medicare dependent hospital designations, and looking to reverse cuts to reimbursement of bad debt and extending the disproportionate share hospital payments, and allowing the rebasing of the Medicare dependent hospital and sole community hospitals as well. And then just looking at revisions to the wage index policies, as well as eliminating the unnecessary critical access hospital conditions of participation. There's a laundry list, but again, things that are making rural hospitals, very vulnerable through the kind of these impacts that they are seeing because of some of the regulatory burdens, but also looking at things like the Rural Health Clinic Burden Reduction Act and some of the things that are supported through there. So modernizing the Rural Health Clinic program, as well as looking at the innovative models that are looking, to kind of address different payment models to support strengthening the rural health infrastructure. So, for example, the Rural Emergency Hospital Improvement Act, of trying to make sure that this model is more accessible and sustainable option for rural communities and hospitals, looking for to consider conversion to this payment model. There's also the Rural Hospital Closure Relief Act, again, looking to support and update the critical access hospital 35-mile requirements and enable them to certify a hospital as a necessary provider. That's kind of been an ongoing fight, but still, very much an impact for rural communities. And then protecting rural access through the 340B program as well. So yes, kind of the main areas, but again, all part of the rural health infrastructure as a whole, and trying to look at those Medicare financing issues that are negatively impacting them.
That's a great way to kind of talk about too, from that rural health infrastructure perspective, right? You got the reimbursement on the one side, but then Medicare regulations and a lot of work from that regulatory perspective as well. Thank you for that. Bill, you get to wrap up on Medicare reimbursement.
Yeah, I want to go back to a little bit real quickly to telehealth in terms of reimbursement. One of as Sarah mentioned, rural health clinics and F2HCs get less than they would from Medicare because of the per visit system. One of the arguments that was made was, well, it doesn't cost as much to do a telehealth visit as it does to do an in-person visit because you're not maintaining infrastructure and all that kind of stuff. And I always found that a curious argument, because during COVID, when I went to get food from a restaurant for carryout, I was paying the same amount of money as I paid if I had gone into the restaurant and gotten the food inside the restaurant. And we have multiple examples of things like that all throughout our economy. Why in healthcare, because you can get something through a remote process, you still had to maintain that infrastructure. You still had to have that infrastructure in order to be able to make the telehealth visit available. And so there seems to be, we have to rethink sometimes the logic we're using to justify certain things. The other thing I want to address, I've worked and talked quite a bit. There's a researcher, a gentleman by the name of Harold Miller. And Harold has done a lot of work with regard to hospital closures and looking creatively at how we can try and address some of the problems. And one of the things that Harold talks about is this issue of standby time. And it particularly is relevant with regard to emergency room and obstetrical care, where there's just a lot of downtime. The volume for those services is not sufficient to generate, because we're on some, even of a cost base, a modified form of a fee-for-service payment system. The volume of services, you cannot generate the revenue necessary to maintain ER obstetrical care. And so I think we need to think more creatively about how we want to make sure that those services are available, and create some alternative payment structures to ensure that those payments are available, because doing it on a service payment linked to service process doesn't work in some areas.
Those are great points. I love the takeout example. Think about it, you could go through your drive-through, the same amount, right? Whether you went to
Yeah.
the restaurant or not. And then, and two, you kind of brought up the whole, the volume isn't there in rural health. And so sometimes you are paying people for their services, even if they're not performing them right at that second. So great points. Before we move to kind of our path forward and to ask you all to share some solutions that you've been thinking about on some of the topics that we talked to. There's been a couple questions that have come in that I'm going to actually pause here and take the prerogative as the facilitator, just because some of them were on the PA and NP and the requirements around, can they start their own rural health clinic? So let me make sure I capture this right. Can a physician assistant or nurse practitioner open a rural health clinic, or are they not able to due to federal requirements for RHDs to have a supervisory doctor on staff? So they I think, just want a little bit clarification on that. So Sarah, do you want to start or?
Yeah. So all rural health clinics are required to have a medical director that is an MD or DO that, it depends how much they are physically present in the clinic. That can vary based on state law and the RHD's policies and procedures and things like that. But they do need to have an MD or DO serve in that medical director role. And so an NP or PA can, own a facility in a lot of these cases, or, provide the bulk of the care, but they still need to have that MD or DO on staff. And sometimes that is a barrier to them opening a facility if they can't get that provider willing to move there to see patients, even on an occasional basis. That can still be a barrier.
Got it. Thank you so much for clarifying that. I'm going to keep pausing for 1 second before we go to solutions. So, Bill, someone asked if you could actually share the title of the paper that you were talking about workforce, and I'm going to bet that it might be okay if we share that paper with the attendees afterwards. But if you could just share that,
Sure.
that would be great.
Yeah, the title is "Where Are Provider Shortages? Reassessing Outdated Methodologies," and it was by Paragon Health Policy Institute.
Great. Wouldn't that be
And
something
you're
that we could
absolutely,
share?
yes,
Okay.
absolutely, Chair.
Wonderful. So for those of you on the webinar, we'll make sure that we share that out with you afterwards. And then I'm actually going to go ahead and ask this other question that came in, and then we'll get to solutions. And maybe Amy might be able to go first on this one, but if not, someone else could jump in. So there was a question around competition when you think about PAs and NPs, as you all talked about, especially with workforce, the ability for some of those providers to provide services and to help those underserved areas. So, but then we're talking about rural hospitals, we're talking about closures. And so is there some competition for those sorts of providers, the physician assistants and nurse practitioners, between the rural health clinics as well as some of the rural hospitals? And how do we is that a fair point? Someone was asking the question about how do we deal with that competition for providers amongst the different settings. Amy, any thoughts on that?
Well, I think, again, just given the shortage that we see in many communities, just the availability of them is key and important to be able to access the NPs and the PAs. And I think, again, it varies by community, just in terms of the models that are available and accessible to patients. But, again, there's still very much a shortage, and looking to try to, how do we, again, invest in a strong safety net? How do we continue to support those that are choosing to practice in rural, with the training that they have as well? And so, again, what's making it most accessible for the patient? But we do see, again, things vary by state, by, different types of impacts, and, what's driving certain areas of the country as well in terms of, patient access.
Great. Bill, anything that you wanted to share as well?
Yeah, I guess I was not quite clear on the question in the sense of competition. I mean, PAs and NPs individually can compete with one another for jobs. What we always look for was a level playing field from a legislative policy, state law perspective, and let them compete based on their clinical skills or ability and who's the most appropriate practitioner. And then there was an aspect of the question of, well, does the clinic compete with the hospital in terms of trying to recruit a finite resource in terms of PAs and NPs. And there probably is a little bit, or there may be a little bit of that. In most communities, I'd say there's probably more likely that the RHC is going to be owned by the hospital, particularly if it's a critical access hospital or a small hospital. And we certainly saw that. You see that in the data where the single largest category of RHCs is what we refer to as provider-based, which essentially is a hospital owned. We've seen a significant uptick in the number of physician PA, NP owned RHCs over the last few years as a result of some policy changes we were able to secure back in 2020. But you know, at the end of the day, the solution to me is, you know, we continue to increase the supply of providers so that we're not in this situation where you're competing for a very limited resource and we have a larger supply of PAs and NPs. And I think we are seeing that. I mean, the number of PA and NP programs today is dramatic. When years ago, when I worked for the American Academy of Physician Assistants, there were 55 PA programs. Today there's, and I think there were a comparable number of NP programs. Today there's over 300 of each. So those professions are working to increase the supply. And I think meeting with a certain amount of success in doing that.
Okay, great. Thank you. And thanks for indulging and asking questions along the way. I was going to wait to the end, but they were very relevant to some of the comments that you all were making. I keep teasing solutions, so let's get to the ideas for solutions. So if you guys could all kind of think about what are your top 2 or 3 ideas for solutions on some of the issues that we've discussed today, and maybe share an example of where there's been a policy or community initiative that's been successful. That would be, I think, great, because we never want to just talk about the challenges, right? We always want to offer some solutions as well. And so, Amy, thought we could start with you.
So as NRHA, you know, we've definitely prioritized a lot of the areas that we've talked about today and that have offered, you know, solutions. So it's kind of our 3 ongoing guiding pillars are, you know, investing in a strong safety net. So looking again at models of care that can enhance the safety net, as well as, you know, different ways of easing some of the administrative burden, you know, that is impacting the safety net, looking at creating a robust workforce. So, you know, how do we enhance GME, graduate medical education? I mentioned the community health worker model that has been, you know, around for decades, and, you know, they are getting finally more recognized, you know, as they should. They were a critical part of addressing the COVID-19 pandemic for rural areas. And so again, looking at the different models that can look at maybe not the usual suspects, as I like to say, but that can partner together to help with rebuilding the workforce team for rural areas, and again, enhancing the lifeline that patients have in rural communities. And then overall, looking at building rural opportunity. We know there's a lot of medical deserts that are occurring throughout the country and leaving, you know, many areas without timely access to care. And so what can be done to address that? We're seeing things like you know, addressing life expectancy, and, you know, just that need becoming greater and greater for rural communities. You know, just because you choose to live in rural shouldn't mean that you die sooner. It should mean that you have great access to quality care, that your life is enhanced because you live there. And not a death sentence. But also, you know, and looking at in terms of, I think the final question and note there about policy impacting, we have seen, you know, some, you know, good addressing of the opioid epidemic in the country, and seen some decreases there, although it's still very much an issue for rural communities. But I think that's one of the examples where we've seen how some of the policies that were developed, some of the programming to address the crisis was very beneficial. A lot of organizations coming together, you know, through coalition building to try to address that, but also the use of telehealth. And again, addressing some of those behavioral health aspects of the crisis as well, to try to, you know, assist patients with that. And so I think, you know, there are a lot of bright spots that we're seeing with some of the technology, but as well, I think the coalitions and just communities rallying together and coming together to address some of the challenges, kind of the biggest support.
Great. Thank you so much, Amy. Sarah?
not to go back and harp on Medicare Advantage, but from a rural provider perspective, if we don't do something about the reimbursements and the administrative burdens that MA plans are, having impacts on our facilities, then it will severely impact those providers' ability to continue to stay financially viable in those communities. If the benefit of being those programs, so critical access hospitals, rural health clinics, is your Medicare and Medicaid reimbursements, and all of a sudden you have a very, very small percentage of your payer mix is traditional Medicare and Medicaid, that the benefit of those facility types no longer holds true, and that is what is holding up access to care in these communities. So we mentioned a couple times throughout this presentation, this panel, another safety net program, so the federally qualified health center program, different from rural health clinics, although sometimes FQHCs can be in rural areas. But I bring that up to say that in the MA conversation, FQHCs do have a protection. So if their contract with an MA plan is for less than they'd receive from traditional Medicare, they'll receive that difference in a quarterly wrap payment from Medicare Part B. And so they are made whole, and it doesn't matter what their patients choose, traditional or Medicare Advantage, they can continue to be financially viable in big part because of that wrap payment. And so something similar for rural health clinics, critical access hospitals are ongoing conversations that we're having. Maybe a wrap payment financed by Part B is not the way that that's going to go. That obviously carries a significant cost, but these are part of those MA conversations. And then one thing that I'm excited about, we haven't necessarily seen these impacts quite yet because it was a regulatory change that just went into effect on January 1 of this year. But historically, RHCs have been limited in the amount of specialty services that they can provide. So it had to be less than half of their services were specialty services, needed to be over 51% primary care. And so that was a bit outdated from the 1977 sort of origins of the program, and there was differences in statute and guidance. And so CMS put that change into effect January 1. I'm excited to see how more RHCs integrate specialty care within their facilities. Like Amy was saying, you don't deserve less access to care, and that includes specialty providers. Again, it's not feasible financially for all providers to bring on full-time specialists in a host of different areas. There are some really interesting models that we've seen of rotating specialists and specialty through telehealth and things like that. So a lot of neat opportunity there. I'm excited to see how that policy plays out that we had worked for a while.
That's great. We keep talking about these 1970s and 80s policies that we need to bring some rural healthcare into the 21st century. Bill, you get to kind of wrap up on solutions here, and then we've got one last question. So, Bill?
Sure. What I'd like to focus in is back on some of the workforce. And Amy touched on the fact that one of the ways that we've been successful at recruiting people to rural areas is either recruiting individuals who grew up there or by exposing individuals to a rural experience during their clinical education. And in terms of the exposure, one of the things I had mentioned, I'm on the board, we have a research and education foundation, is we're providing scholarships to PA and NP students who will do a clinical rotation in rural health clinics. One of the things that you find is that it is much more difficult for a student to do a rural rotation than it is an urban rotation, simply because most of your educational programs are urban or large city based. And so as a student, it's pretty easy. I'm in the dorm or I'm in an apartment to try and find some place that's in the town, in the city. So in Washington, D.C., for example, if I'm at George Washington University, I'll just go, and if I want to do an underserved rotation, I'll do it at an FQHC in Washington, D.C., rather than going to a rural health clinic in West Virginia, because where am I going to live while I'm there? How am I going to get there, et cetera? And so the scholarship that we're providing is intended to cover housing and food or transportation costs to try and eliminate that barrier. And if you talk to programs, and I mentioned how much our PA and NP programs have grown, the program administrators and directors will tell you that the biggest challenge they have to growing their programs are clinical sites for students to do rotations. And so we need to encourage more rural hospitals, rural clinics, rural practices to being open to taking students to do clinical rotations, because that's a key for increasing our rural workforce, is exposing these students to a rural practice during their educational phase to increase the likelihood that they will practice there when they graduate.
Great. I love how you guys have all touched on some sort of aspect of some of our discussion today when you're talking about solutions. So thank you so much for all of that. We are almost at the end. However, we have talked about quite a bit of stuff today. We are coming up on about 50 minutes of discussion on rural health. So if you can pick one thing, and one thing only, that you want to leave with the audience today, if they don't remember anything else, will be the one thing that you would want them to take away from our conversation today. And so, Amy, I'm going to start with you.
Well, I think, we're really good about talking about the challenges that are happening in rural America. We've got that, nailed down. We know the obstacles, but I think what, really stands out and what I hope folks can take away is the rural opportunity and the impact we can have when we empower rural communities with the resources that they need to really address these challenges that we all know so well. And I think oftentimes rural, there's a negative narrative about rural communities and, kind of where they're at in the place of things. But we've learned, and I think COVID-19 showed us, and just throughout time, that innovation really happens in rural communities, that there's so much resourcefulness there. There's a connection with, again, those not so usual suspects that happens in rural communities that you don't often see in other areas of the country. And so there's a real power to that. And I think that that is sort of, what could positively impact the future of rural health, is thinking about, where it can be strengthened and where they can build off the strengths that they already have in rural communities.
That's a great closing thought. I really like that. Thank you, Amy. Sarah.
Sure. I'd echo Amy's points, and I'd also say, or ask you all to remember that rural is not and should not be a buzzword that's just used to support these communities or these populations when, it fits an agenda correctly. And, both parties have been guilty of this at different times. I spent a lot of time on the Hill, and, people don't often say, no, of course, like rural's not a priority for me, right? Like that, you don't hear that, but what does that sort of statement actually translate to in actions? Is it really just, a word that they know appeals to a certain audience, or something that, they're actually committed to finding, like Amy said, solutions to address these challenges? So, rural's not a buzzword. I'd leave you with that.
I love that one too. It's like, don't give up, keep going. Bill.
Thank you. And thanks for allowing me to be a part of this. One thing. I would, in some ways, echo Sarah's comments, in the sense that there are some organizations, no one on this call, who only remember rural when it comes to, they want to cut X, Y, or Z payments. And so organizations that really don't ever talk about rural suddenly are saying, well, you can't do that because of the impact it would have on rural hospitals. You can't do that because of the effect it would have on rural healthcare. I happen to live outside of Washington, D.C., and we have a large health system here. And I'm on the health board in our county. And as a consequence of that, we get to kind of oversee some of the things they do. They're currently sitting with a $9 billion reserve fund as a nonprofit organization, of accumulated monies over the years. I dare say there's no rural hospital that, has, even if they have a reserve fund, doesn't even begin to approach the kind of numbers. And so be cautious of some of the people who are using rural in order to try and argue against certain changes, because they're remembering today, but they're only using it. And then tomorrow, when it comes time for the kinds of things that Amy's talking about, that Sarah talking about, where we need to make improvements in those programs, suddenly they'll be silent again when it comes to rural hospitals, rural clinics, and rural providers.
That's a great way to wrap up. You guys are obviously all in it for the long haul when it comes to rural health. And that brings us to the close of this month's Northern Virginia Health Policy Forum. So I can't thank you enough, Bill, Sarah, and Amy, for sharing your knowledge, your expertise, your story, and obviously your passion for rural healthcare with us today, and for giving us your perspectives on solutions. And so I love that we end with solutions and last thoughts, because it's easy to talk about the issues, and I really appreciate everything you guys have been saying about where we go from here and how do we get a rural America that has access to healthcare. Before I close, just want to make sure and remind everybody, there is a message in the chat from Annie with links both to the Applied Policy Monthly newsletter and to be able to view our Northern Virginia Health Policy Forum website, which will have more in-depth insights into current and perhaps future health policy. Thank you so much for joining us today. We appreciate you taking time out of your day. I know you guys are all busy. And with that, we're going to wrap up and enjoy
Not
the rest
me.
of your day, except for Bill, who apparently is on a beach and he's retired. Thanks so much for joining us. Enjoy the rest of your day.